So let's kick this off. Maybe we'll have a few more folks trickle on as we get past the hour here, but I did want to get us started and introduce Dr. Dan Rubin from Temple Health, and they're our fourth group to present at our shared learning series for the No Diabetes by Heart and Diabetes Insight Initiative. I do want to thank Jefferson College Population Health and Alexis and team for hosting us today, and of course our sponsors, national sponsors Novo Nordisk and Eli Lilly, and our founding sponsors AstraZeneca, Sanofi, and Bayer. And so Dan, if you would take it away, introduce your team, and then we can jump right in.
Thanks, Greg. Okay.
Okay, looks good.
So we will be sharing a presentation investigating patient perceptions of factors that may optimize diabetes self-management. I'm Dan Rubin. I'm an endocrinologist at Temple, associate professor and director of clinical research in this section. And then I'll be passing it off to first Deb Swavely, who's senior director of nursing research at Tower Health and was formerly a collaborator at Temple, and then Sarah Bass, who's associate professor in the Department of Social and Behavioral Sciences and director of the Risk Communication Laboratory at Temple University. A brief statement of our background. So, as you're all probably aware, self-care management in diabetes is very important for the management of diabetes and often suboptimal in populations that are vulnerable in a number of different ways, often marked by low income and racial and ethnic minorities. And these are, of course, influenced by social, cultural, economic, and literacy factors, many of which are grouped under the heading of social determinants of health. There's a number of interventions for diabetes self-management that do improve short-term glycemic control, but these interventions are different and they vary, and so there's not much ability to generalize and or scale them to larger populations. And further, few implementation studies have focused on these vulnerable populations specifically. So there's a need to really understand why these vulnerable populations are not as good at self-care and how can we help them be better. So the two goals of our project were to identify the facilitators of and barriers to optimal diabetes self-management in adults with type 2 diabetes who live in the Temple service area. And then second, to follow it up with a design of a testable intervention based on this qualitative data analysis. We had some theoretical underpinning for how we designed the study. And this was really the brainchild of Sarah and Deb, who have some complementary expertise in qualitative analysis, and put it under the rubric of extended parallel processing model, which we use to guide sampling specific types of patients that we organize in this new way by understanding and assessing their self-efficacy by a validated scale called Diabetes Empowerment Scale, and then assessing their perceived threat from diabetes and heart disease using this one question perceived risk tool. So we administered these two scales. The Diabetes Empowerment Scale is an 8-item, 5-point Likert scale that allowed us to rate people as either high on self-efficacy if they were above the mean, or low on self-efficacy if they were below the mean. And then this simple one question perceived risk tool, which is copied here, paraphrasing for brevity, compared to most people, what are your chances of having future health problems because you have diabetes and or heart problems? And then depending on how they answered that question, which was a 4-point Likert scale, either high threat or low threat from their disease. And so that leads to this 4-box stratification scheme where we can group people as either high threat, high efficacy, high threat, low efficacy, low threat, high efficacy, and low threat, low efficacy. And these the sort of general characteristics that we can understand a priori from other literature that we thought would apply to the situation of diabetes. So these high threat, high efficacy people are people who take protective action to avoid risk. They understand that their disease it can cause them trouble, and they have high self-efficacy to deal with it. The high threat, low efficacy people understand that they have threat from their disease, but they're too afraid to act, and they try to reduce their fear in order to make themselves feel better. The low threat, high efficacy people know what to do, but they're not so motivated to do it. They don't feel threatened by their disease. And then probably the worst category to be in is low threat, low efficacy, who don't feel at risk from the disease, and they don't know what to do about it. Our methods were screening patient charts in the electronic health record to find those who were English speaking, adults 18 years or older, have a diagnosis of type 2 diabetes, they live in the primary service area for Temple, and they receive ambulatory care in either endocrinology, medicine, or family medicine practices. We had our study coordinator, Shanisha Allen, screen and approach patients who had scheduled appointments, and patients were then enrolled in the study if they agreed, and we were sorted by into one of these 4 EPPM cells and enrolled until that cell was saturated up to a maximum of 10. And saturation is defined at the point at which we felt that doing another interview would not provide any additional information. And then our coordinator interviewed these patients individually in private, following a semi-structured guide. Our enrollment scheme was as follows. We were able to enroll 41 patients. 6 were excluded for various reasons. And then we were able to stratify 35 patients according to the EPPM scheme, giving us 12 in the high threat, high efficacy group, 10 in the high threat, low efficacy group, 8 in the high threat, high efficacy group, and 5 in the low threat, low efficacy group. We did lose a few patients along the way, and so we were able to complete a total of 25 interviews. And for those of you who aren't as familiar with qualitative research, this is not an uncommon sample size for qualitative studies. They really, a single interview can be very rich in terms of data. And so it's not so much a numbers game like we're used to seeing with quantitative studies, but it's a matter of how good an interview can you get. And even with our 3 interviews, you'll see that we're able to pull out some interesting information from them. Some sample characteristics to give you a sense of who these patients are in more detail. Average age was 57, and a very nice split in terms of male, female, about half and half each. The vast majority of patients were Black, about 20% were Hispanic, and only 4% were white. About 40% had Medicaid, 32% had Medicare, 28% had private insurance. The education levels for highest education, more than half of them had either high school education or less. 30% had some college, 12% had some sort of technical, vocational, or community college education, and no one had a full college, 4-year college degree. In terms of their diabetes characteristics, average A1C was 9%. Mean duration of disease was 14 years. BMI was 32.5. And 60% of them had microvascular complications of some kind. 40% of them had macrovascular complication of some kind. And the distribution of diabetes medications are shown here. So 32% of them were on some kind of oral medication only. 24% were on insulin only. 44% of them were on a combination of oral and insulin. And all of them were taking some kind of diabetes medication. Pretty typical distribution for people with type 2 diabetes. So at this point, I will turn it over to Deb to start us off with the qualitative analysis.
Thanks, Dan. So our interviews were audio recorded and then transcribed verbatim, very typical in a qualitative study. We started a code book prior to doing interviews based on 2 of our theories. And then inductively, as we read all the transcripts, we added codes to that code book. What we did was Sarah and I, as 2 independent coders, coded each transcript. Then we came together and formed consensus about what the code should be, how they're defined, and how we would move forward. We then moved all of our transcripts and codes into a qualitative software program called Deduce to help us with our main coding and our analysis. What we ended up doing was analyzing our top 15 codes, which we reviewed. We took excerpts from those particular interviews and drew some conclusions based on our thematic cohesion. Next slide, Dan. What you get in Deduce is you can actually form a word cloud of your top codes. And so you can see those here. Not having some of the definitions for the codes may make it a little difficult for you to understand what they mean. But to give you an example, extrinsic factors and extrinsic barriers, so things outside of their outside of themselves, were really our 2 leading codes that they felt were driving some of their ability or disability or inability to move on with self-care. And there were other important things here. So if you go to the next slide, Dan. These are the top codes that we then used for our analysis. So you can see, for example, the extrinsic barriers and facilitators were the top with 149 and 141. Something that happened to them post-diagnosis, 103. And at the end of our list was self-efficacy itself being 38 codes and trust being 42 codes. You can go to the next slide, Dan. So I'll start off just summarizing why this is important in thematic results, and I'll hand it over to Sarah to do a little more digging in terms of what we found. First of all, why is it important to understand how they are different amongst these groups? Well, if you look at this and you look at the fact that we have very limited resources and we need to direct those resources to the appropriate patients, what we're learning here are the things within each of these cells that will help us direct resources in terms of what patients need. So to start off, some of our thematic results were that externally, they were listing things like lack of transportation. That's not a surprise to folks who work with this population. But they also had internal factors such as apathy or barriers that they ran into. But we found that our high efficacy groups really did report greater problem-solving skills. So they're able to, we used a theory called sense making. They're able to take in new information, work it through, and actually learn how to problem solve in terms of their self-care skills. Those who had a high disease threat and high efficacy described their type 2 diabetes with a matter of factness, and they owned the disease, where folks who had low efficacy did not have well-regimented plans, and they really more relied on others, families, partners, those sort of things, and sometimes questioned the reality of their disease. Problems adhering to diet and exercise recommendations were ubiquitous through the group, but our low efficacy participants described their health in more negative terms, and again, relying on healthcare providers' advice rather than have their own problem-solving skills in place. All our groups expressed the importance of social support, and we found no differences there. One thing that was interesting, because Dan, when you were talking about the amount of macro and microvascular complications, is that the patients in our high threat group weren't necessarily in that group through the course of their disease. So they move around as they progress with their disease in terms of where they fall in the cells. And many times with these high threat individuals, there's a trigger. I saw a family member with diabetes who had an amputation. I realized that if I didn't start taking care of myself, I wasn't going to be here to be with my children. But so these really important triggers happen, and then they seem to move into that higher cell where they're more independent and they work towards problem solving by themselves. So I thought that was an important finding. And Sarah, I'll hand the rest off to you.
Okay, great. Thanks, Deb. And I just want to say my Wi-Fi is kind of wonky because I'm not at home at this moment. So if I freeze or drop off, Deb, you can.
I'll keep on going.
Okay. Dan, you can go to the next slide. So we just wanted to kind of give you a sense of what some of these things look like from a qualitative perspective, and some of the quotes that we found in some of these codes. I'm not going to talk about all of the 15 because that's a lot. So we picked kind of the first 3 or 4 to give you a sense of some of the differences that we saw as being indicative of what we were seeing across these 4 cells. So this one specifically looks at extrinsic barriers, and this was the number 1 coded one. I think it was 140 some codes that we found throughout all of these transcripts. And so these high efficacy groups, both the high threat and low threat, you see kind of this, taking charge of their disease and questioning things, being very active. So this idea of kind of, this is on me, I have to do this. So this is a good example of that. I'm by myself. Now that I do by myself, I choose to do, and no one's looking over my shoulder, making sure I do the right thing. So we saw a lot of that kind of language about kind of taking ownership, having agency in doing those kind of things. On the other side, then, if we look at those low efficacy groups, and again, didn't matter what the threat level was, you see a lot of the reasons are much more outside of themselves for, not complying with things. So it's usually, I have too much stress, or it's too much money, or my family doesn't support me. So it's more dependent kind of on these other things that are outside of that time. So this is a good example of that. My depression kicks in, and then I go to munching on something that I'm not supposed to. That's when it happens, when I get depressed, and that's because of a lack of not being able to do what I need to do, health-wise, money-wise, food-wise. Next. The other thing we saw were extrinsic.
She froze. So the other thing that we saw was extrinsic factors. Our high efficacy groups had real evidence of being active in their disease management. They're looking for things that will help. They're looking at things that are on sale, if finances are trouble, looking for the right environment to be in that will support them. Are you back, Sarah? No. So an example of that is I'm always looking for stuff on sale. I got a car so I can go to different stores or different places, catching the sales, looking at flyers. I catch some of the sales and I jump, and excuse me, I go to where they got the stuff the cheapest. I didn't have no education on it. So, I had to start Googling and reading and watching TV and paying attention every time I hear diabetes. So again, efficacy, a real important piece to understand with our patients. Our low efficacy group, that they want others to do it for them. I told my kids, okay, and my kids are really effective at what I eat, how much I eat, me taking my meds. I can't remember, but through the health insurances, they send me copies of brochure in the mail. Next slide, Dan. I don't think we got Sarah back, did we? All right. Our high efficacy groups have very detailed and very specific accounts on how they manage their disease. Normally consists of maybe a baked potato. So this person's giving you an example of exactly what they eat. And we heard a lot of that. I have some juice. I have me some juice with sugar-free, very conscientious, very regimented, and can tell you exactly what they're doing in their self-care. Our low efficacy groups are much less detailed and had far fewer codes on a plan. They're reactive to physical signs, and I just know. So yeah, I try my best to be, what's supposed to be a little bit healthier. I try to eat, like what you have in the, I like what I have. I will eat chicken, but it's not fried. So the differences here, I know it's not here in a quote, but I know when I was reading it, our low efficacy group would talk about why they don't need to monitor their blood sugar because they don't want sore fingers, and they just know how they are by how they feel. And our high efficacy group is monitoring, they're tracking it, they're problem solving. So a significant difference between those groups. Next slide. Differences in triggers. I talked about triggers before when I started to introduce this. So our high threat groups, again, I mentioned this before, discuss specific things that were associated with taking better care of themselves. My father died when he was 48, and I thought I better take care of myself. I don't have to read the second quote, but getting advice about how he is going to stop drinking, stop smoking, and get on the road, because he was on the road to bad luck. So he's getting on a better road now. Where our low threat groups did not talk about triggers as better ways to take care of themselves. I didn't like it, nothing I can do about it, but you go to the doctor. They prescribe medicine. So I could survive the best way I can, take the medicine I get, the stuff I get there. Next slide, Dan. And the presence of social support I mentioned in the beginning didn't find differences really among the cells, and social support was important no matter where they fell. And I think Dan mentioned having found that in another qualitative study. So this is kind of triangulating that. Many people talking about their support being their healthcare team, the people around them that care, and the people in their family telling them if they're doing wrong or to stop doing this. Next slide. So about time point, another one of our big codes, our high threat, high efficacy group had the most meaningful and the most frequent comments, able to reflect on their disease and its management, talking about how, and again, I mentioned that they didn't always stay in one group at a time, but as they were getting a little older, they had better knowledge, experience. They felt they had more power than when they were in their 20s. Finding it was a blessing they had bariatric surgery. I look at my body and I see the progress I've made from last year until this year with my sugar getting better. I had diabetes for 15 years and lost my leg due to poor healing wounds. Very, very meaningful comments that they reflect on what's happened to them and they change their behavior because of that. Our low threat groups did not describe their disease in the same way, not introspective, just referred to dates of things. Next slide, Dan. So our observation and conclusions. Dan, do you want to do this part?
Yeah, sure.
Okay.
So, so putting all of this together, these are our observations that it seems that EPPM is an effective and novel way to group patients with type 2 diabetes. It seems that, and you probably noticed in the distribution of who we were able to enroll in the different cells, we didn't have very many patients in the low threat and particularly low self-efficacy patients. And it occurred to us, well, those are the people who aren't threatened by their disease. And those are also the people who don't have a high degree of efficacy. So they're less likely to show up for clinic visits, and they're also less likely to participate in research. So they're just a tough population with that combination. And because of that combination, having a low perceived threat from your disease and a low self-efficacy probably impedes self-care in diabetes. And so following that through to a logical next step is that it's probably more important for low self-efficacy patients for providers to identify and then address barriers to care than it is for the high self-efficacy patients. And furthermore, low efficacy patients probably need more help to translate plans into action. And so assessing perceived threat and self-efficacy may identify patients who need specific intervention to improve their type 2 diabetes, self-care, and thus control. If you're going to be at ADA this summer, we welcome you to check out our poster on this, presenting some of this work, which will be this summer in June. So then, following up these observations and conclusions, and this is particularly where I'm interested in feedback from the group. You know, what do we do with this? What are the next steps? How could this lead to further study and a potential intervention? Well, we have two main thoughts. One is in terms of piloting some kind of intervention. Well, first, you could administer these EPPM tools to sort patients with diabetes by self-efficacy and perceived threat. And then, having identified those low efficacy patients, you could give them more specific instructions. For example, instead of just saying like a garden variety prescription for take your insulin 3 times a day, I have like a very detailed sheet that lays out each time point and exactly what dose you should take, and maybe a sliding scale, and it's much more detailed. A low self-efficacy patient would benefit more from that than a high self-efficacy patient. And low efficacy patients probably just need more help at the point of care, which for them is going to be the home, right? So they might need community health workers. They might need a home visit with a nurse. They probably need diabetes education, and they might need a care navigator to navigate through the system. And each of those kinds of people can give them very specific feedback on what it is that they need to do to turn plans into action. And it also occurred to us that thinking about low threat people and triggers for taking their disease more seriously, that maybe peer support might help those low threat people to take their diabetes more seriously and consider it a higher threat, and thus take better care of themselves. And the other thing that occurred to us, as we see that the EPPM structure is a reasonable way to sort patients, it would be interesting in a larger data set to sort more patients into these 4 cells and then correlate it with clinical markers and outcomes. So I'm going to shift gears a little bit from our qualitative study and focus a little bit more on our population as a whole. And Greg and Elise had asked me to talk a little more about what we're doing in the Temple population. So I thought I would start with the data that Greg's team, Roy Furman, was kind enough to analyze when we handed over to them about a year ago. And so these are our demographics of people with type 2 diabetes or heart disease. We're about 50% Black, 20% white, and 25% Hispanic. And it shows that over time, there's been a little decrement in the proportion of Black patients, a little increase in the proportion of white patients. And this was a little over 11,000 patients over about a 10-year period. In terms of insurance distributions, 50% of patients have Medicare, 15% have Medicaid, 25% have some kind of commercial insurance, and then a smattering of other insurances in the remaining 5%. This is our prescribing trends over time in patients with type 2 diabetes. And what you'll see is that over time, insulin analogs got a little bit more common, sulfonylureas came down, metformin got a little bit more common, but what's most striking is the GLP-1s and SGLT2 inhibitors over this 10-year period, particularly starting around 2013, 2014, a real increase such that about 20% of this population was on a GLP-1, and about 12% of this population was on an SGLT2 inhibitor. So a few of the things that we've done system-wide for improving type 2 diabetes care are every year we do a CME conference for our Temple-affiliated community private care practices and practitioners on diabetes management. We get a lot of good feedback on this. Various members of endocrine section do it. I've done them for a few times. And I feel like this is a nice way to bring them up to date on current practices with diabetes. We recently had a medicine grand rounds on SGLT2 inhibitors that was very well received, and it was a three-part shared presentation between someone in endocrinology, nephrology, and cardiology, discussing the now robust body of evidence in each of those three domains, and how there's really a whole lot of benefit to these agents. And then lastly, as I mentioned at our last session, we're just starting a clinical trial using dapagliflozin, one of the SGLT2 inhibitors, upon discharge from Temple for patients admitted with heart failure. And this is a AstraZeneca-funded, investigator-initiated study led by Emory that's being done at several sites across the country to better understand the risk-benefit ratio for starting one of these agents on actual discharge from the hospital rather than just in the outpatient setting. So I'd like to close with a number of acknowledgements. This was a pretty big team effort. We had a number of people working under Sarah Bass's direction, helping with the qualitative analysis, transcribing and coding. Shanisha Allen, our study coordinator, did a fantastic and challenging job enrolling patients and getting their data and getting interviews. Often it took multiple phone calls. We had a number of clinical collaborators in endocrinology, family practice, and general internal medicine who helped us access to the patients. We had some consultation with another faculty member at the university, Dr. Zisman Alani. And then thanks, of course, to Greg, Elise, and Roy at Diabetes Inside for providing us this opportunity. So that'll close, and I'm happy to take questions.
Great, thanks, Dan and Deb and Sarah. That was excellent, and team. I'll ask a question here and then open it up to the rest of the folks here. I really like the paradigm you described and how potentially useful that might be as a way to identify patients who need more intervention based on low efficacy, low threat. And what are your thoughts on that group, the low efficacy, low threat group, in terms of some of their mental health challenges? I don't know if that was part of something you could maybe glean a little bit from the interviews. And then I think more interestingly, your thoughts around the potential interventions that you described. The idea of peer support makes a lot of sense. Potentially pairing a high efficacy, high threat individual with a group of the others as a way to kind of motivate them, or show them that you can get to this place, you can self-manage better. Obviously the resources are extremely challenging in your service area, but these type of interventions I think have a lot of potential, and kind of curious your thoughts on if you've prioritized some of these or what kind of plans you have to maybe start piloting some in the near future.
Dan, I'll answer the question about the mental illness. I think that's a great question, Greg, and I think we did not see that in that particular low efficacy, low threat group. But one thing we can contemplate when we're going to trial this tool in a practice, and we're going to attach to some clinical markers, is we can also look at some comorbid conditions, and that could be one of them, and that will help to answer that question. So I like that suggestion, and with a greater sample size, I think we'd be able to explore that.
Thanks, makes sense. And then in terms of some of the potential interventions that might arise from this, the peer support, is that something you're kind of actively thinking about standing up, or is it just kind of in the idea phase right now?
Yeah, we're really in the idea phase right now. We finished the qualitative analysis very recently. Actually, it's not totally done. There's still a few more things that we would like to do with it. But this is the meat of it, and we were really just recently at the point where we could take a look at what we have and start to glean some informed ideas about what an intervention might look like. So we're really just sort of putting together what would make sense in terms of this EPPM strategy.
Great. And one last question, and thanks for sharing some of the other kind of system-wide efforts to address diabetes, cardiovascular disease. And I think we had touched on this briefly at the last meeting. Like you said, we were in looking at different institutions and some of the uptake of the newer agents, the SGLT2s, GLP-1s. Temple was kind of leading the charge, if you will, in terms of kind of earlier adoption or more frequent utilization of those therapies in the population. And you think some of those things you listed are reasons for that? Any other thoughts on, why that might be different at Temple? Could it be just, simply health plan differences? I know you guys have some slightly different health plan through health partners, right? For a lot of your population, is that maybe some of it we've not investigated a lot on our side in terms of payer differences there, but just curious if you had any other.
Yeah, I'm reasonably confident that our CMEs for the primary care practices have helped. We started doing them maybe 5 or 6 years ago, more or less, when you start to see that uptick in their use. And then otherwise, I think a lot of it is driven by the payers. And there has been increasing uptake by the payers of at least one agent in the major classes. But I honestly have no idea about differences in our payers versus the other major systems.
Yeah, something we've not really looked that deeply at, just other than kind of stratifying by commercial insurance versus Medicare and Medicaid, but not the specific commercial insurance.
Yeah.
Any other questions for Dan and team? Everyone wants to get outside for the last bit of sun, I think, here. So.
Hi, Dan. This is Roy.
Hey, Roy.
We've looked at across the country, the relationship between age and A1C, and we always find a very strong linear inverse dependency. Younger patients having, as a group, much poorer control than older patients. In your 4-quadrant analysis, although it's a smaller number, did you see anything that correlated with age in your data set?
It's such a small sample that it'd be hard to look at. There's only 5 to 10 people per cell, so it'd be hard to look at trends by age for A1C. I guess we could look, but I think probably the most we could say is look at the A1Cs in the different 4 cells and see if there's any striking, obvious differences. That's not something we've done yet.
Or what, maybe a binary categorization, because we typically see half the patients are above the mean A1C level of the population, and they're the younger ones, and the older patients are the ones that half is below. And so perhaps you could see that, or you mentioned you're doing additional studies that, might be something looking at to see if can find a way to target people at a younger age and earlier on the onset of diabetes.
Mm-hmm.
The other question I had, when we looked at insulin, both at Temple and Jefferson, Temple, again, like the SGLT2s and GLP-1s, had more insulin usage by about a factor of 2 in the population with poor control. But in both groups, the efficacy of that insulin as a population metric was very poor. The average insulin in those groups average A1C on those groups on insulin was 11, and should be able to do much better. Again, looking at your different threat efficacy regimes, are there anything about the people on insulin that fall in one category or another that might be amenable to getting better control with that subset?
So is the question, are there differences in like the diabetes medication distribution
Right.
of the EPPM cell?
Right.
Yeah, that's not, we haven't quite gotten to the point of doing a bit of more of a quantitative analysis of these EPPM cells, and that's something, yeah, one of our next steps to look at distributions of different clinical characteristics across these EPBM cells. Yeah, it'd be interesting to see, and it'd be interesting to see if that has any sort of correlation with A1C across the 4 cells.
Because another one of the things you mentioned was, where does a team direct their resources to have the biggest impact? And so age and therapeutic modalities and proportion of patients in each of those groups, can in part guide where do you start with an intervention, and hope to be able to see a reasonably strong signal that the intervention is efficacious or not.
Yeah, for sure. Yeah, it'd be interesting to see if for example, the low threat, low efficacy group have higher A1Cs and but they have a lower proportion of insulin use, then well, there you go. They need some more nudging in order to intensify their therapy. So we'll have to look at the data and see what comes out of that.
Any other questions? Okay, well, we'll wrap this up for today. Thank you all for taking some time out of your evening. Really appreciate it. If you do think of anything, please email me and we'll route it to the right folks for a response. And as we mentioned, we'll get this up online so you can share with your colleagues. And again, thank you to Dan and all, and really appreciate you sharing your work with us today. And we'll look forward to working with you over the next several months to see what comes of your findings and how you're kind of directing this insight into some future interventions. So thanks again, and take care, everyone. Have a good evening.
Thank you.